as it should have been treated. Many a times people feel that since somebody is aging and they cross the age of 60 or 70, and then it is natural for them to have memory loss or the cognitive impairment. However, same is not the truth. There are some regions, there are some pathological regions which lead to dementia. And there is a very good correlation between the high life expectancy and the Alzheimer's, which is a leading cause of dementia. This data is from Japan. This data is from Japan, which has the highest life expectancy, and you can see the data shows that by 2060, the number of people who will have dementia might go as high as 1,200 out of 10,000 people. And as we know that healthcare infrastructure in India in last couple of decades have increased significantly, and life expectancy also is increasing. So India is also not alien to that occurrence, and you can see that there are two independent reports, one from Money Control, which says that by 2050 the and the Niti Aayog information which says by 2050 you will have more than 13.5 million people. Currently there are 4 million people, and that too, I'm sure these 4 million people are those people who are living in metro cities, urban setup, and who have access to the diagnosis and they get diagnosed. There would be millions of people who are in our rural setup who are living with dementia, living with Alzheimer's, but they do not have access to diagnosis, and they never come to know whether their cause of their dementia is because of aging, because of some vascular issues, or is it really Alzheimer's. So on that note, I would like to share that Agappe and fujirebio are going to launch a panel of biomarkers which are going to make diagnosis of Alzheimer's very much easy and possible. And those biomarkers are going to, okay, so another thing, the progress of Alzheimer's. So by the time somebody comes to know that they are having cognitive impairment, their neurological functions are getting impaired, and they do not have the same neurological function which they have had in their youth, or they are forgetting important things. That is actually too late, because the pathogenesis of Alzheimer's starts much early. So if you see here, so the preclinical stage of Alzheimer's disease, that is called preclinical Alzheimer's disease, the presence or absence of pathological changes associated with Alzheimer's disease is determined by molecular imaging, amyloid and tau imaging, or body fluid biomarkers. So this is the point wherein Agappe Specialty Diagnostics Division aims to intervene and provide these body fluid biomarker, because the molecular imaging, amyloid and tau imaging, is not easily accessible. The green curve which you can see, this phase is known as mild cognitive. So this is the stage when patient or their relatives or their caregivers come to know that, okay, this person is having some issues in terms of their start at much early stage. The different dotted lines represent different diagnostic tools. So the first one is the CSF amyloid level, then second one is amyloid PET, then the light blue is CSF tau, or they start changing their normal much before the patient reaches into mild cognitive impairment. So everybody will have access to these MRI FDG PET, but if we are able to offer a biomarker which is based on body fluids, I am sure that would be much more helpful. And this is why, if you see the table above, the beta amyloid 142, beta amyloid 140, total tau and phosphorylated tau, these are the 4 biomarkers which we are in position to launch. As Mr. Naveen said rightly, that we have received our required licenses, our manufacturing is in position, and we will be launching these parameters. They will be commercially available very soon. Within a month, we should be able to offer it to you. Okay, and we do understand that when I say that we want to make it accessible to everyone, and more people should have access to getting diagnosed whether or not they will have Alzheimer's going forward. So CSF is a sample type which is not a very preferred, okay? Because drawing CSF is a invasive procedure. It has some complications. So considering that, we Agappe and fujirebio are also working really hard to make sure these parameters and many more are also available on serum or plasma. Okay, so maybe in another couple of quarters you will hear another good news wherein these markers and also some more markers like genetic markers like ApoE4 and Apo, those parameters also we are striving to make sure they are available on blood so that we start treating Alzheimer's as a disease and not related to age, because of course the Alzheimer happens in old age when a person reaches to the age of 60, 70. But age is not the reason. Age is a coincidence that the Alzheimer happens in old age, but that is not the reason. Okay, so to have the ability to diagnose it is very important, and we will make sure that it is available. We will of course need a lot of support from you, wherein making sure that it reaches where it is intended to reach, and then we will work with you. Of course, we have a beautiful panel, wonderful luminaries from neuro and pathology who are available among us, who will share more light on Alzheimer's and its implications going forward. I'll move to the next one. That is the another parameter. So from neuro, and now I'm going to the liver cancer, hepatic cell carcinoma. Now, all of us know that there are a lot of parameters already available to diagnose whether somebody is hepatitis B positive or not. For that, there are a lot of parameters, correct. Why? But when patient is clinically treated, because there is a lot of treatment available for hepatic cell carcinoma, wherein patient starts feeling well clinically. However, the core antigen of hepatitis B still remains in the hepatocytes. Currently, if somebody wants to understand that whether or not patient is totally free from hepatitis B virus or hepatitis B virus still exists in the body, the only way possible is to do the liver biopsy. And all of you would, echo with the fact that doing a liver biopsy is not the best thing if somebody would like to, and it's not easy as well. So in that case, we are going to have a marker named HB core related antigen, HBCRAG, what we call as a product name, that has excellent correlation, because as you know already, the cccDNA, covalently closed circular DNA, is the core of the virus which exists in the hepatocytes, and from there, whenever it finds a suitable environment, of course it will do its transcription activities, and the disease might relapse or the patient might have another bout of infection. So to diagnose that, we have got HBCRAG, which has got excellent correlation with HBV cccDNA. So without doing the the liver biopsy, the clinician would be able to understand whether the DNA is there and if at all it is active. That way, we are going to intervene at a stage wherein liver biopsy can be eliminated by doing HBCRAG itself. And we will be the only company, we will be the only service provider who will have complete solution of liver management. So, from HBV carrier to chronic hepatitis to cirrhosis to SCC, in all stages, we will be with you, wherein our offerings, our solution will help you at each stages. So, when we are talking about diagnosis and monitoring, as I said earlier, there are markers available. They are available with us as well. Our product name is HBsAg Quant and HBV surface antigen. Then when the patient is in treatment stage or a reactivation management stage, again we have the HBsAg Quant and HB core related antigen. So even at this stage, the HBsAg Quant as well as HB core related antigen in combination will be able to share a lot of information where how the patient is responding to the treatment, once treatment has been, completed, the dose has been completed, is there any activity or a reactivation? So both these parameters put together will be able to give you that information as well. At the same time, when the patient reaches into the risk group for HCC, hepatic cell carcinoma, so in that stage, we also have, of course, PIPCA2 and AFP, this is a marker of interstitial lung diseases. India being a developed country has a lot of chances and the instances of interstitial lung diseases are increasing. Compared to the developed countries, India has a lot of risk of having more and more interstitial lung diseases. And in many cases, the other causes of lung diseases like pneumonia, bronchiectasis, and pneumonia due to hypersensitivity or other reasons. It is very tough to differentiate interstitial lung disease from other causes of lung issue. So the KL6, if you can see these dots, KL6 is active or its values are high only in the interstitial lung diseases, not in the healthy or pneumonia or bronchiectasis patients. So this is a specific marker for interstitial lung diseases which will be available and we will be able to offer you. Okay. There is a study by PGI Chandigarh led by Sahasdal Dhuria and his team, which has established that India being a developing country has a risk for interstitial lung diseases compared to the developed countries. So of course, the combination of the novel biomarkers, which I already discussed, related to Alzheimer's, liver disease management, and pulmonary diseases, we will be able to offer some solutions for which there is still problem exists. Not only that, the specialty diagnostics division and this equipment will also be able to offer you, especially in Alzheimer's and neuro. We will have NFL. We are going to launch maybe in another couple of quarters the neurofilament light, which will be a marker for neurodegenerative disorders like multiple sclerosis or something like that. So that also we will launch, and these products would be available on these equipments. So you can see the equipment on my left, the small equipment with very small footprint on that table that we call MISPA I60, which is based on CLIA technology, chemiluminescence enzyme immunoassay, and we are using ALP AMPPD combination, which has got the highest sensitivity possible. This instrument has number of assay per sample which can be run are 8. The throughput is 60 tests per hour. Here, I would like to just say that sometimes the throughput is mentioned which is variable. So if I say 60 tests per hour, some equipments, of course I would not name them, they offer you 60 tests in particular arrangements. So if you take only one parameter, you run them, you will get 60. Once you mix different analytes, let's say you are doing thyroid, fertility, you mix them with infectious markers, then the effective throughput comes down to half. However, since this instrument is based on mono cartridge system, the throughput remains 60 irrespective of the test combination. So whatever test combination you choose for your patient sample, the throughput remains 60. This is because the reaction time has been standardized to 25 minutes for all the parameters. So whatever parameter panel you choose, the reaction time remains same. And since the reaction time remains same, the combination does not affect the throughput. Coming to the sample capacity, it has got a sample capacity of 36 samples, which includes three stat samples as well. Of course, for any laboratory, whether small or big, once instrument is in operation and you receive any urgent sample for which the analysis is rather more urgent, you would like to have the facility for stat. And this instrument offers 3 positions for stat as well. The reagent capacity is 112 tests on board in the combination of 14 cartridges for 8 cases. So 8 parameters can be loaded in one go and 14 cartridges per parameter, so that amounts to 112. Since it is the reagent type is mono test cartridge. Now, the basic core of this technology or this instrument is the mono test cartridge, because Many of you have worked in laboratories, and you would echo with me that when you open a reagent bottle on day one, the performance of those reagent bottles, whether it is a chemistry or immunoassay, is something different. And when you are going to test the same reagent on day 7, day 14, day 21, whenever, same performance would not be achieved. For the simple reason, when a reagent bottle is opened, it will come into the contact with atmosphere. It will come into the contact with a sample probe, which is going to get washed after every use. The washing solution is coming into contact with sample probe or reagent probe, sorry, and water is coming into the contact. Water is the biggest contaminant available in the lab, right? So the reagent stability of bottle type reagents, of course, will not be same on day 4 or day 15 from day 1. However, when I'm introducing the mono test cartridge, so each and every cartridge is sufficient for only one test. So once a cartridge has been utilized, there is no more reagent which is going to be utilized next, and there is no wastage as well. So even for the parameters for which the sample load, the test load in a day is not that high,